Good afternoon and welcome to Psychology Grand Rounds. We have a great talk for you today, as always. I'd like to introduce our speaker and our moderator to you. First, we have Dr. Jacob Appel, who is going to be our speaker for today. Dr. Appel is currently a professor of psychiatry and medical education at the Icahn School of Medicine at Mount Sinai in New York City, whereas he is the director of ethics education in psychiatry, the associate director of the Academy for Medicine and the Humanities, and the medical director of the mental health clinic at the East Harlem Health Outreach Program. Dr. Appel is the author of 5 literary novels, 10 short story collections, an essay collection, a cozy mystery, a thriller, 2 volumes of poems, and a compendium of dilemmas in medical ethics. He is vice president and treasurer of the National Book Critics Circle, co-chair of the Group for the Advancement of Psychiatry's Committee on Psychiatry and Law, and a counselor of the New York County Psychiatric Society and of the American Academy of Psychiatry and Law. So just a few credentials there for you, for Dr. Appel. And Dr. Ronit Groffman Margalit, who's going to be our moderator today, is an assistant professor of psychiatry at the Icahn School of Medicine at Mount Sinai. She is a licensed clinical psychologist at the Child and Adolescent Complex Care Team in the faculty practice at Mount Sinai Hospital. Dr. Margalit specializes in working with children, adolescents, young adults, and families using evidence-based treatment, including cognitive behavioral and psychodynamic therapies. Dr. Groffman's area of expertise includes mood disorders, anxiety disorders, and identity development. So we have a wonderful talk for you today. And Dr. Appel, whenever you're ready.
Thank you for having me. I will begin by saying I really appreciate that generous and exaggerated introduction. But to my mother, I am still her son is not the rabbi. So
Mhm.
it's all a matter of perspective. Um, I
Just
am now going to share my slides. Uh,
just a moment, Jacob. Sorry, I
sure.
need to do um some adjustment here. Just give me a second. Um, and I think you should be good. Yeah, go ahead.
Perfect. So I should begin by saying that I am a psychiatrist, and I imagine most of you are psychologists. And that actually matters here in two senses. One, I'm going to talk about boundaries today, and some of the rules and ethical guidelines are different for psychiatrists and psychologists. And my slides generally cover the psychiatry ones. I will mention the psychology ones as well, except in the one area where I actually could not find the psychology. But the more important, larger point I want to make is that in most of these cases, there is no logical reason the rule for psychiatrists and the rule for psychologists should be different. And in fact, the average consumer of healthcare probably doesn't know at the outset the difference between a psychiatrist and a psychologist. So having different sets of rules may actually confuse people and lead to mistaken beliefs about what the boundaries are. So one area I've written about and I'm interested in is making the rules uniform across the mental health professions. With that in mind, I should say I don't get paid enough to have any disclosures. So I'll talk briefly about boundaries in medicine and briefly about the concept of the difficult patient. And then I want to talk a little bit about sexual boundaries and then a bit more about non-sexual familiarity violation, which I think are the issue most likely to come up in your practices. Then talk a bit about financial conflicts of interest. We talk about these a lot in the research setting, but very rarely in the clinical setting. And then at the end, I have a couple of strategies and a case for you all to think about. So some of this language may be familiar to many of you, but I at least want to review it at baseline. So Gutheil and Glenn Gabbard initially coined the phraseology boundary crossings and boundary violations. And they describe boundary crossings as deviations from standard normal practice that are non-exploitative and generally don't harm either the patient or the treatment relationship, which is distinguished from boundary violations that are deviations that are harmful either to the patient or the treatment relationship. And it's worth noting that the same behavior can be a boundary crossing with one patient, but a boundary violation with a different patient. What I want to emphasize is these are role-dependent phenomena. What do I mean by that? I mean, if I go to a bar one night and I find an attractive person and I give them my phone number and take them home with me and we end up getting happily married, I hear that happens to people. If I do that, I've done nothing wrong. But if I do that in my office with a patient, I've clearly done something wrong. It is not the nature of the behavior that is problematic. It's the nature of the role that is problematic. So it's very different, for example, from people who are sexually assaulting patients without even their understanding of consent, where the behavior itself is unethical. So why do I mention difficult patients? Well, first I want to define them. What I mean by difficult patients are not disruptive patients. Disruptive patients are actually fairly easy. You take steps to keep them from being disruptive. They're not symptomatic, synonymous with treatment refractory patients. Rather, they are patients who, in a specific physician or psychologist patient diet, produce a transference counter-transference relationship that makes treatment very difficult. And the reason I mention this is because I do workshops, or have done workshops around the country, where I ask people to write about their most difficult patients. And overwhelmingly, people do not write about the kinds of patients you might think of. If I asked you off the top of your head to name difficult patients, many of you would probably cite the kinds of patients that James Groves mentions in his famous article, Taking Care of a Hateful Patient, where he describes dependent clingers, entitled demanders, manipulative help rejectors, and self-destructive deniers. On a different occasion, we can discuss whether this article is at all accurate or even appropriate, but that is sort of the conceptualization of difficulty. These patients actually aren't very difficult from a ethical standpoint, because if you draw boundaries and enforce them, ethical issues won't arise. The ethical issues, it turns out, and the difficulty arises overwhelmingly in the opposite. When I do these workshops, people describe patients who they like too much. They are beloved patients. They're either overly relatable, people think there, but for the grace of God go I. They're inspiring in some way. I don't like the term VIP patient, but sometimes they're celebrities or people who've accomplished something that the providers, admirers, are even jealous of. They're very sympathetic. Their story produces a lot of wishing that you could do something to make their lives better. Or sometimes they're joyful patients. The classic joyful patient is Beth March in Little Women. No matter what you do to her, she bounces back and tries to see the good side of life. I give you a slide from picture of Turgenev's The District Doctor, where he has so much in common with the patient that at her bedside, he eventually falls in love with her. And that is what we're trying to avoid. Most boundary violations occur not in the setting of patients you dislike, but in the setting of patients you like too much. Mm. So with that in mind, I want to begin by talking about sexual boundary violations. So many of you probably are at least familiar, even if you did not stand in front of a room and say it, with the Hippocratic Oath, which primarily was a guild rule. It was designed to keep doctors from interfering with the turf of non-doctors and vice versa. So it contains rules like don't teach the secrets of medicine to anybody except the sons of other doctors, and don't perform surgery, which they call cutting on stone, presumably because surgeons will then start performing medicine back when the two were different fields. There are only 4 ethics rules in the entire document. 2 of them are very controversial today. One says you should not perform abortions. One says you should not assist in medical aid in dying. But the other 2 are generally accepted. One is to maintain confidentiality, and the other is not to have sexual relations with patients. It's interesting. It says male or female, even though all physicians in the Hippocratic model were male, suggesting it was somewhat egalitarian. On the other hand, it also speaks of slave patients and free patients, so it wasn't that egalitarian. What I want to emphasize is legal prohibitions, unlike professional ones, on sexual relationships with patients are very recent in origin. So probably most of you know of Jung's relationship with Sabina Spielrein, which has been written about extensively, but Sandor Ratto married his analyst, Benešel and Bernfeld married patients, Sullivan and Alexander had long-term patient relationships with patients who were hospitalized at the time. So the ethical rules may have been fairly clear, but the legal rules were not. As recently as 1972, psychoanalyst Marty Shepard, some of you may know that name, wrote a very well-selling book called The Love Treatment, Sexual Intimacy Between Patients and Psychotherapists, which you can still buy on Amazon or eBay, in which he interviewed people who'd had sexual relationships with their providers. And his book was rather eye-opening because it described some people whose lives have been ruined by this, and other patients who said this was the best thing that ever happened to them. Uh, I don't know how representative the sample was. The state medical board went haywire. They actually revoked his license. And he said, but I haven't done anything wrong. I'm a researcher. I'm not having affairs with patients. You just don't like the data I'm producing. He, to my knowledge, is the only person ever to go to court in New York State and have his license reinstated um, for violating an ethical norm the state simply refused to accept legally. However, the controversy around his book led to significant changes. As an amusing aside, by the way, 30 years after this, maybe a little more even, I get a call from my agent one day who says, we sold your book and the publisher wants to meet with you. Now, trust me, I am a very insignificant person, certainly in the writing world. Publishers do not want to meet with me. Who is the publisher? It's Marty Shepard. It turns out that a week after getting his license back, he decided that writing and publishing was more exciting than psychology or psychiatry, and he quit and changed fields. And he wanted to ask, do I teach his case in my courses? And the answer was no, but now I do. So this is the legacy. So the other major changing event that sort of put the idea of sexual misconduct not just being untoward, but truly criminal on the public agenda was the case of Roy v. Hartog. And it's often said that egregious or extreme cases change the law. Well, Renatus Hartog may have been the worst psychiatrist in the history of the United States. He's dead, but if the state wishes to sue me, I will fight them out on. He had an Upper East Side practice in Park Avenue where he only treated young women with borderline personality disorder. And he only offered one therapy, sexual relations with him. And he then billed these young women for his sexual services. Many of them had no idea this was not what mental health therapy was all about back in the 70s. Couldn't go on the internet. They were often from rural areas, come to New York. They were naive. It was horrific. He also, by the way, at trial, was discovered to be a fake Holocaust survivor who'd been receiving benefits from being a Holocaust survivor when he wasn't one. Needless to say, that played over really badly with the court and the jury. And it changed the law. Julia Roy, who sued him, was a young woman, very brave young woman who actually challenged the system. Prior to this time, you could not recover from malpractice if you sued your psychiatrist or psychologist for having a sexual relationship with you. It was considered outside the purview of their medical practice. The only way to win these lawsuits was if you happened to be married, your husband, and it was generally gendered, your husband could sue the psychiatrist under the principle of alienation of affection, which was an old concept that said that if somebody alienates the affection of your spouse, usually your wife, from you, you have a legal claim against them. As antiquated as that may seem, it's actually still the law in North Carolina and Mississippi, and there are occasionally multi-million-dollar payouts over this. So if you choose to have an extramarital affair, and I'm not encouraging it, choose your jurisdiction very carefully. The key take-home point from this all is that this changed the law in New York State and eventually nationally. And suddenly, states started enacting statutes that caught up with the courts that criminalized sexual relationships between doctors and patients. I will mention the APA, American Psychiatric Association, banned relationships in 72, the AMA not until 1992. And when I say these relationships are non-consensual, they are not non-consensual in the sense that people like David Newman in the psychiatric ER at Sinai, who's having sex with patients while they were anesthetized, Robert Haddon at Columbia, who was sexually assaulting obstetrics patients. At the time, the patients thought they were engaged in consensual activity, but the duress of the circumstances meant that they really could not meaningfully consent. What's interesting to note is the early cases dealing with sexual misconduct, the reason the courts view it as unethical has nothing, or malpractice, has nothing to do with power dynamics, nothing to do with consent in our modern sensibility. Instead, the rationale was you were interfering with the transference and the countertransference and undermining the therapy. It was inconsistent with traditional psychodynamic models, which is why well into the 1970s, early 1980s, if your psychiatrist or psychologist seduced you, that was a malpractice claim. But even if your obstetrician or gynecologist seduced you, that was not a malpractice claim in most states. They were not mismanaging the care. They were simply transgressing a non-medical boundary. It's worth noting that in malpractice, the only area of law you don't have to prove damage is in sexual misconduct. If the misconduct itself occurs, it is presumed the patient has been harmed by it. It's also worth noting it's actually not a criminal offense in New York State to have sex with a patient. It is only criminal offense in New York State to have sex with a patient if the patient thinks it is part of the care. Obviously, it's unethical and grounds for malpractice. But in theory, if you tell the patient this is not part of the treatment, then you are no longer criminally liable. So, what might be a situation in where it is not unethical to have a romantic relationship with somebody under your care? And this applies to the medical model, but I'm sure there are psychological models too where it might apply. And the key answer is where the romantic relationship predates the medical relationship. So the example I always use is you're a radiologist and your long-term girlfriend injures her foot while you're playing tennis. You take her to your clinic. She has to register to get an x-ray. So you get the x-ray, you read it. She's fine. But then 2 years later, you break up and she files a complaint with the medical board saying, well, I was your girlfriend and you examined my ankle and you actually sent a bill to my insurance company. And that might be bad practice, but the medical board is not going to come after you for that. The general rules that I encourage people to follow are the same rules the American Academy of Pediatrics applies to parents treating children, which is that routine care in the context of a prior romantic relationship may be acceptable, but you should never prescribe scheduled substances, psychiatric medications or interventions, or invasive procedures. And this, although psychologists may not be doing this issue may come up when you have patients who you may think their providers were engaged in misconduct, and that may help you shape whether or not you need to report them. It's worth noting these rules are very hard to enforce. Studies show that, for example, 6 to 10% of male therapists and 3 to 8% of female therapists have been sexually involved with a patient. The data for physicians is older, but it suggests similar numbers. And it's really hard to actually enforce these rules because John Darrow is a good example. He was an orthopedic surgeon, he still is in Iowa. He met a woman healing an injured ankle. I don't know if it was broken or twisted. He asked her out on a date during the treatment session. They went on to get married. They had children. A colleague filed a complaint with the state medical board. He brought his wife and his 3 lovely young children to the state medical board hearing. They all said what a wonderful person he was. The state medical board fined him $5,000 and told him not to do it again. So after the fact, unless there is an objection from the victim, it is very hard to make a claim. How about former patients? So there are 2 different approaches here. I actually think the American Psychological Association's approach makes more sense, and I'll get to it in a second. But you should know that in psychiatry, it is a bright line rule that you may never have a romantic relationship with a former patient. In fact, the APA strongly discourages behavior that might lead to that because the data shows that there's a significant slippery slope pathway for this kind of misconduct. First, you meet a patient. First, you drive them home from the office if they can't get a ride. Then you meet them for coffee to discuss their care. Then you go over to their house to drop something off, and suddenly you're in a romance. The AMA, on the other hand, adopts the rule that it's not a matter of time, but it's a matter of duress. So with a former patient, as long as the relationship is over, you need to ask yourself whether or not the patient still feels undue pressure from the nature of the relationship. And the nature of the medical relationship will shape, obviously, whether or not there's future duress. I always like adding this because it's a bizarre rule. The American College of Physicians says that it's very difficult to judge these cases. So before you have a relationship with a former patient, you should ask a colleague. Please do not make me that colleague. So the American Psychological Association actually combines the APA rule with the AMA rule in the sense that for the first 2 years, there is a complete washout period. You may not have a relationship. It is a hard and fast bright line rule. But after that, it is a discretionary rule that puts a burden on the provider to establish there's not duress. And what's really helpful, which only the Psychological Association does, is to actually give you guidelines on the kinds of factors to take into account, but the amount of time that has passed, nature of the relationship, the circumstances of termination, the client's illness, et cetera, et cetera. I would, and I have written this elsewhere, I would suggest that psychiatry actually adopt this model, which works fairly well. But it's also worth noting that every state has not adopted this model. And there are some states where psychologists are still bound by a bright line rule. And in fact, in one case, a number of years ago, a psychologist had done an intake with a man a number of years before she coincidentally met him in a blind date personal ad, one of those like advertisements in the back of magazines, which gives you a sense that this is an older case. She did not realize, and he did not realize that she'd done an intake with him until their 3rd date. They had a good laugh about it many, many years later. And then they got happily married. And before they got married, she sent a letter to the state psychological review board, whatever it was called in that state, to keep them aware of the situation in case anybody ever brought it to their attention, so she'd be in the clear. And they had a hearing for her and revoked her license. It is a bright line rule in some states, even if it's not a rule for the American Psychological Association. It's not the case in New York, by the way, but you should know the rule in your state. Um, so I will mention a bit about malpractice. Um, should the key ethical question is, should insurance cover you for sexual misconduct? And if I ask you to take a poll, I won't. And you only got 1 second to answer. As most of you would say, medical malpractice should not, psychological malpractice should not cover you for insurance, because you view it as a moral hazard. Some of you may disagree, but that I've done this poll for many years, and that's the answer I usually get. I'm going to suggest I can change many of your minds. How can I change your minds? So this issue came up in most of the major psychiatric and psychological organizations in the mid-1980s, when their insurance policies stopped or substantially limited coverage for this kind of misconduct. It turns out that people who have affairs with patients do not sit down one day and say, I'm going to have an affair with a patient, and as a result of that, I'll probably lose my license, and my family life will fall apart, and I'll be shamed in the community, and I'll be bankrupted, but at least my insurance will cover me. It's not the mindset people have. They often tend to be people who are, I won't say narcissistic, but think they're going to get away with this. So they're not worried about getting caught in the traditional sense. Who is actually victimized if malpractice does not cover these individuals? The victims, who can no longer sue to be made whole again. So in the 1980s, it was actually a combination of female providers in psychiatry and psychology, and victims' rights groups that fought strongly to keep insurance covering these kinds of transgressions. They lost. Why did they lose? Because insurance companies have something called secondary insurers, insurers who insure insurance companies. So like when 9/11, when the trade towers were destroyed by terrorists, there had to be a backup insurance company, which the insurers couldn't pay that. And the insurance company for all medical malpractice insurers, the backup insurer, is the venerable firm Lloyd's of London, which called behavioral health organizations and said the percentage of payouts for sexual misconduct, which now exceeded 30% of all cases by the 1980s, was so high that if they didn't drop coverage for this particular kind of transgression, they would lose their secondary coverage. This gives you a sense of how strong or how significant this problem was by the early 1980s. And how does this concern you? A lot of you are thinking, yeah, but I am never going to have an affair with a patient. Though I will say that 3 different residents at Mount Sinai or in the healthcare system I teach in, who I have given this lecture to, have lost their licenses over the years for having relationships with patients. So it may be, as I will add, those of you who remember our former chair several chairs ago. So this is not an unheard of phenomenon. That is Mike McIntyre, my former fellow, former resident. I have to emphasize he did not have an affair with a patient, so people don't mistake that. Instead, he had a patient who came to him. You can ignore the example. I changed it slightly from my previous talk, but I will describe what actually happened. It was a patient came to him in our outpatient clinic and said that she'd had a relationship with her former psychiatric provider. And she had left that provider because she felt it was inappropriate to be seeing someone she'd recently broken up with romantically and needed another provider. But she did not want him to tell anybody because she had no hard feelings and didn't want to get the other provider in trouble. And that created a challenge for Mike. He didn't know whether he had an ethical duty to breach confidentiality to help prevent this from happening again. And the data shows people repeat this offense over and over again, or an ethical duty to the patient to not breach confidentiality and her trust, particularly knowing that she probably wouldn't come back for care and will be severely damaged beyond this already presumably traumatic experience. So we actually called the legal department at Sinai and asked them what to do, and they did not know the answer. And then we called the state and asked them what to do, and they could not give us an answer in real time. So then we actually surveyed all 50 state medical boards and wrote a paper you can read in the Journal of the American Academy of Psychiatry and Law that details the answers for psychiatry. And in short, the answer for psychiatry in New York is you are a mandatory reporter specifically of sexual misconduct by providers in all situations. It is one of the few grounds there's an absolute duty to breach. This differs, though, from state to state for psychiatrists. I will confess, in the last day or so before this talk, I have tried to find the answer for psychologists. Maybe somebody knows, we'll put it in the chat. I could actually not find the answer. My guess is it's going to follow the same rule in New York, but it's actually not codified in any place I could find. But it is something you probably want to know in advance in case this ever happens. I mean, you do not want to have to figure out in the moment. So a related question that comes up is what about sexual relations with the relatives of patients? So I like choosing an oncology case because it makes it a bit more stark. So Dr. Arrowsmith is a pediatric oncologist. He's a grade school child Lucy for an annual visit after her recovery from childhood leukemia. During the course of care over several years, strikes up a friendship with Lucy's mother, Mrs. Z, who was divorced, and this leads to a romance. When her estranged ex-husband, Mr. Z, finds out about the relationship, he complains to the state medical board. He argues the relationship would compromise his daughter's care, and he wants Dr. Arrowsmith disciplined. Should he win? So, and then the next question is, how far away from the patient does the relative have to be for this rule to apply? So it turns out the courts have generally distinguished between medical providers and behavioral health providers. So in Roe v. Bennett in Maine, which is one of the earliest cases, a therapist was having a romantic relationship with a girlfriend of her patient. And the state court, when this was discovered, ruled that was misconduct and malpractice. However, in Pennsylvania, when Mr. Long went to Dr. Ostroff for his care, family physician, and said, I think my wife is cheating on me. And Dr. Ostroff prescribed him an SSRI and said, it's all in your head, don't worry about it. And this went on for a decade when Mr. Long discovered that his wife was actually having an affair with Dr. Ostroff and then sued. I kid you not, I've actually talked to Mr. Long about this. He lost because, well, a psychiatrist or psychologist might have that obligation. A general provider does not. The American Academy of Pediatricians, by the way, strongly advises against relationships with such patients or patients' parents, but does not require it. Mount Sinai has changed its rules over the years since I got here. So back in the days when I was a medical student, if you rotated through a clinic and some older patient said to you on a one-time visit, you're a nice young man, you're just a medical student, my great niece is single, here's her number. The attendant would say, take it, but don't do whatever you want with it. I don't really care. You're never going to see her again. By the time I was a resident, what I would tell people is, it probably isn't appropriate to get involved in this sort of way, but don't be impolite. Just take the number and then just discard it. Now we are taught to tell the medical students there is an overt duty to turn down the number, say they can't accept it at all, to enforce the boundary a priori. So the culture has shifted. For what it's worth, Ohio was the first state to take action against doctors having relations with family members of patients. That's Gary Gladue. He had a romantic relationship with the mothers of 6 pediatric patients. I should add consecutively, not concurrently. 5 of them were not troubled by this at all. The 6th one, only in hindsight, under pressure from her ex-husband, and filed a complaint with the state. Several of the women testified on his behalf, saying, we don't think he did anything wrong, but Ohio did, and they suspended his license. And that rule has since spread through much of the U.S. Though the case has not come up legally in New York State, my guess is that if it did, you would find yourself on shaky ground as a provider. But lest you think this rule is a good rule, there clearly has to be some outer bound. I was involved in the debates in Mississippi in 2017 over House Bill 40, which proposed banning relationships between physicians and all key third parties of patients and former patients, including anyone in a close relationship with a patient, not limited to spouses, partners, siblings, parents, children, guardians, and proxies. And it placed the burden of discovering this upon the provider. You can think about this for a second, why it's a problem. Let's say I go back to that bar again and I see that same person again. Before I ask them out, I got to take out a Rolodex of all my patients and say, so are you anybody's sister on this list? Are you anybody's cousin on this list? It doesn't work. So obviously there has to be some parameter. And it might make sense that there be a different parameter if you work in a busy emergency room in New York City than if you're the only pediatrician in Nome, Alaska, where everybody's related to everybody. So I will not put you all on the spot for the sake of time and ask you who that man is. When I give grand rounds, some elderly person in the front row very confidently says they know him, but I assure them they didn't, because that is my late grandfather who died a very, very long time ago. But before he did, he ran the Army's facility for people, what they call the criminally insane during World War II. And then he got a job back in New York City. And one of his parts of his job was evaluating patients for discharge from the state psychiatric hospital. And the way he did this is going to be the early 1950s, might even be the late 1940s, was he would take them out fishing on his boat in Sheepshead Bay, all alone. And he felt comfortable alone with the patient on a boat. And he would bring the patient home to have dinner with my mother and my step grandmother. And if my mother and my step grandmother felt comfortable with the patient, then he would clear them for discharge. So you could ask yourself whether this is a good idea or not. I would suggest it's probably not a good idea. It is very clearly, in the language of Guttheil and Gabbard, not a boundary violation. It is a boundary crossing. He's working solely in the patient's interests. It's presumably not going to damage the relationship. It might even improve the relationship. Nonetheless, it's something we agree one shouldn't do for the most part, which suggests the Guttheil and Gabbard model of crossings and violations is probably not sufficient enough. And the second half of what I'm going to talk about today, I want to emphasize, is there actually are three different areas you want to examine in non-sexual boundary violations. And I will add non-sexual boundary violations, unlike sexual boundary violations, are very poorly regulated. They're very rarely discussed. But the three questions you want to ask are: first, am I acting in the patient's interests? That is the class for my own. That is the classic Guttheil and Gabbard crossing violation question. But the second question we often fail to ask is, am I excessively entangling myself with the patient? And the third question that I will mention briefly, we'll not discuss in detail here, but you can read my articles and question online, or am I acting transparently so the patient and I have the same understanding of the boundary process? It's a rule of three from my perspective. You have to meet all three standards where you're going to get yourself in trouble. So I will briefly talk about the issue of whose interests you're serving. And I like to distinguish between the following two cases. You're an aspiring author, and one of your patients is an editor at a major publishing house. And you ask people to take a look at your psychiatry memoir, hoping that she'll buy it. Now, that is clearly a boundary violation. You're doing that just for you. But in contrast, think about the following. This is actually a true story that happened to me. I'll give you the actual version. I was at the corner bookstore on 94th Street, I think, giving a reading for my book, and one of my patients walked into the store with her daughter. My patient was 94 years old. I've been treating her for quite a while for distress after the passing of her husband. And she said to me after the reading, she coincidentally walked in, "You know, Dr. Appel, I wish I could buy a copy of your book, but I can't afford one." She meant nothing by that. I went over to the counter, got my wallet out, bought her a book, signed it, and gave it to her. Now, that is definitely a boundary crossing. My argument that is not a boundary violation is that is unlikely to recur again, and it's unlikely to exploit her or relationship in any way. Had I been doing psychodynamic therapy with her, I would not have done that. Had she been a patient with significant boundary issues, a borderline personality, I would not have done that. But you do not want to forget as a human being what you know as a provider when grappling with boundary issues. I don't know if any of you know Alan Collins will remember this case, but it occurred in 2010 and it cost him $650,000. He was a provider at Lenox Hill, and he had what seemed like a good idea at the time, as they always say, two patients who were having a very hard time meeting members of the opposite sex to date. So we decided to fix them up. This was not the wisest choice. And the way he explained it during his deposition was they felt isolated, they had an inability to meet other people, and he didn't want to leave them to the mercies and uncertainties of a dating service. So in theory, he meant well, if we give him the benefit of the doubt. They both described having a terrible date, and their diagnosis will be clear once I tell you what happened on the date. It's worth noting that nothing untoward happened on the date. They just didn't care for each other. And they both left with the same impression. I can't believe that my psychiatrist thinks so little of me that he would fix me up with this other person. And then they got together and they sued him, and the courts awarded $650,000, or actually they may have settled for this after the depositions, under the principle that he'd entangled himself unnecessarily in the lives of the patients, and that could be foreseeable damage. And that is what I don't think we think about enough. So the area, by the way, where entanglement occurs most often is an unlikely one, when you don't think about it. It's when you offer guidance or advice to the relative of the patient incidentally. So somebody's on the phone with you talking about their problem, and they say, "Oh, you know, my sister also has a problem." You talk to her for 30 seconds, and you talk to the sister and give her some advice. Now, we often consider that case in an ethics situation about your duty to the sister and whether or not she's become your patient and what your obligations are. We never talk about the case in relation to the boundary issue with your primary patient, because suddenly you're in a situation where you're getting information for two people from the same family, often the same household, one of whom is under your care, one of whom may be under your care, but not with the same purpose. And if you end up taking that second person under your wing in some way or learn information from them, you create the risk of a boundary conflict. What I always emphasize is when you take on a new patient, the most important question to ask is how did they find you? Why? Because if you find out how they found you, you're going to prevent situations from arising where 6 months into the therapy, they say, oh, I didn't tell you. My ex-girlfriend, who I'm talking about, is the provider, who is the patient who recommended you, and you're still seeing her. That's who Judy is, who I've been talking. Oh, your patient Judy, you didn't realize it. And you're going to have this challenging situation, either having to refer the patient out or figuring out how to navigate this. Related to that, my general rule, and I will add, this rule applies in a place like New York City. I don't know if you can stick hard and fast to this in a small rural community, but in a place like New York City, there is never a reason to treat two members of the same household, adult members, children are different, but adult members, unless you are doing joint care with them. So it's reasonable to do couples therapy with two people, but you shouldn't be just doing independent therapy with a husband and wife living under the same roof, no matter what ground rules you set up, because conflict will arise. I will skip that for the sake of time. So the kinds of questions to ask about excessive entanglement. The red, by the way, are things you shouldn't do. The greens are things you shouldn't do. I will send the slides out so you can debate the yellow with your friends and family. You have a partner who is a victim of intimate partner violence, and you fear for her safety. She's unwilling to stay at a shelter because you do not trust them. So you offer her use of the empty apartment above your garage for several days until she can make arrangements to travel to her family out of state. And I will add, you have no ill will, no ulterior motive. You're just trying to help for goodness of your heart. The reason you should not do this is not because it's a boundary violation. It's because of the implications of entanglement, of which there are at least three. There probably are more. But the three most significant ones, I've actually surveyed providers on this, are one, because the patient's spouse shows up at your door and doesn't understand that this is simply an innocent relationship and therefore leads to violence either with you or with the patient. But two, because you may establish an unreasonable expectation in this patient that when he or she goes elsewhere, she's going to get the same level of care or the same level of protection. And if she doesn't, it may lead her to end up in a dangerous situation. And third, and most concerning, if word gets out that you do this, other patients may come to have the same expectation. And if you meet it, you will undermine boundaries in situations where it may not be appropriate. But if you don't mean it, they will be betrayed, feel betrayed that you don't have the same standard for all your patients. So which is why I give the opposite case. Your patient of many years dies. You perform effective ECT on the patient years earlier, and the patient has always been very grateful. To your surprise, the patient's daughter calls and says, putting together a memorial book for my father. Hope this isn't imposing. Were you willing to write a few words for my dad to be included? It would mean a lot to my mother. To me, this is not a problem at all. Why? Obviously, it's your discretion whether you want to do it, but I don't think it raises an ethical or boundary question. Because unless this is an Irish novel, your patient is dead and you're not going to encounter him again. Because the patient's family clearly knows about the care relationship or they would not be able to call you. So you're not revealing any secrets. You're not having a situation that's likely to recur. Even if other patients become aware of this, the downside of this expectation is a very low one. There's contrast, for example, with going to someone's Christmas dinner or somebody's daughter's wedding, where if they have more daughters, or even this daughter doesn't do well in the wedding business, they get married again. Or they may then invite you to Thanksgiving the next year, and when you can't come, they may take it personally. So the questions to ask are, will it set up an unreasonable expectation with other patients they find out? And will it set up an expectation with this patient that is likely to recur that might not be fulfillable? I will not in great detail, but when I send the slides that you can review this, discuss the third issue, which is making sure that your goals and the patient's goals for any boundary crossing or boundary issue are aligned. But I will give you a classic example of what you should not do. Let us say you have a patient who you believe has a romantic interest on you or inappropriate countertransference and wants to ride the elevator with you down from the office at the end of the day. So this patient sets up the last appointment of the day. Now, for you, it is really convenient to do that because nobody else is willing to take that time slot at 6 o'clock on a Friday, and it's hard to fill. And otherwise, you end up sitting in your office doing nothing. Now, even though you haven't done anything wrong, the very fact that you're having a different motive from the patient over behavior that transgresses or approaches a boundary is likely to create a problem in the long run. And finally, in our last 5 minutes or so, I want to mention a bit about financial violations and conflicts of interests. So the example I like to start with is a patient, an outpatient psychiatry or psychology. You practiced for many years of treatment. You can decide what you treat him for, is terminating care and moving to Florida. He'd like to make a large donation to the hospital to endow a chair for his longtime provider. How should this be handled? Now, I can tell you the development office would be thrilled if this patient gave $4 million in your honor, even if the patient is not giving the money to you directly, or even endowing the chair for you to get your salary paid with it. The reality is, I assure you, Renee Kahn will send much better plastic fruit and flowers to your office if somebody donates $4 million to the department the day before. However, there are two reasons at least you should not do this. One is obvious, but the second one is more concerning. The first one is, let's say your patient goes to Florida and he looks around and he says, wow, I don't like it here. There are alligators, it's really hot. Comes back to New York and he wants to be your patient again. Now you have someone who you're indebted to, indirectly at least, for $4 million, who's back in your care. Or you have to turn them away. Either way, that's a problem. But that's not the big problem. The big problem is your patient's cousin calls. And it turns out your patient's cousin is not the ideal patient. He explains to you that he just was released from Leavenworth prison from axe murder in his last psychology. And he is only willing to engage in psychotherapy if he can actually bring his vodka with him to the office and drink it during the process, or some other violation of your basic boundaries. And you say to him, I really don't think that I'm the right provider for you. You need a higher level of care. Maybe you should see Dr. Appel. You wish him well. And then he says to you, so how much money do I got to give? I know cousin Fred gave 4 million. How about if I give 6 million? You do not want to be known as the behavioral health specialist who sells out to the highest bidder, because that will begin to happen. And I won't mention any names, but we all know people in the city who do exactly that. And it's not to their interest or their patient's interest for that matter. So I mentioned these rules are very poorly regulated outside the physician-patient, the research setting. It's worth noting that you are fiduciaries for your therapy patients, for your whether a psychiatrist or a psychologist. What that means is you cannot take steps that directly harm your patient financially, unless they deal with billing or relation to your own personal conflict, even if you don't get the information from them. So let's say, for example, you have a patient who owns a company and is the sole owner, and you discover information that you can publicize or sell short and bankrupt him and make a fortune, and you don't discover it from him. You still can't do that. It's still a violation of ethical norms. You have to put his financial interest reasonable first in those circumstances. As a general rule, you should avoid commingling resources and entanglement or interdependence of any sort. Some of you are thinking, when am I ever going to be asked to commingle resources for the patient or engage in financial entanglement? So when you do this a long enough time, it will happen. Usually people who mean it in the most innocent way. So the kinds of areas it comes up, or somebody will say to you, doc, I'm afraid when I die, my children won't be taken care of in the way I want, or their colleges won't have the money set aside. Can you be the signator on the account that makes sure my kid's college is paid for? Because I don't trust my second spouse to do it. All you got to do is be a signator in the state. That is a grave mistake. That entangles you in a way you don't want to be entangled. Or I just was involved in a lawsuit with my employer. I have this large account they've set aside in escrow. You need to be an independent signer on the escrow account. Will you be the independent signator? You should not do things like that, no matter how well intentioned. Patients will trust you, but it's still not a great rule. So the kinds of things you shouldn't do are taking stock tips from a patient. Years ago, there was a patient who would come to the dialysis center and would give the nurses tips on which horses would win at aqueducts. He clearly knew something everybody else didn't know, because the horses always won, and it took a lot of effort to keep people from betting on those horses. Employing a patient, or innocently doing things like saying to the patient, oh, your niece needs an internship this summer. She can come and stay in my office 1 day a week when you're not getting care. Or, oh, your niece cleans offices and she can't find work. She can come in and clean my office for cash 1 day a month. Any entanglement like that will eventually get you in trouble. Investing in patients' products, facilitating payment in other areas. But it's worth noting that sex is not like money in the following sense: that while you should never have a romantic relationship with a patient or former patient in psychiatry, or I guess in psychology when duress occurs, the rules are a bit laxer with money, in the sense that if you're acting out of the patient's interest and not financial interest of your own, and you're not going to make a profit, a financial interaction with a patient is presumably okay. So a classic example of this would be, you have a patient who covers from care, founds a nonprofit devoted to a certain kind of psychotherapy, and wants you to sit on the board. Now, that is a financial entanglement, but if you're not getting paid for doing it, the state medical board or the Office for Professions will not look askance at it. And I will finish with, in 1 minute, a case for you to think about. Lucy is a celebrated actress with a very busy filming schedule for a television show. She sends you a message at your private email, which is obtained from a friend of a friend, stating that she was recently diagnosed with anxiety and asking you to see her on Sunday mornings, as is the most convenient time for her, and offers to pay whatever additional costs are entailed in the visit. Before you have a chance to respond, a case of wine arrives at your office with a note that reads, "Thanks so much for trying to accommodate my schedule. Your new patient, Lucy. How should you proceed?" So the answer I usually get from trainees is you should not treat this patient. You should send her a certified letter and let her know that you are not going to be her doctor, because clearly she is violating all sorts of boundaries before she steps into your practice. That is only half the answer. It is very clear that you also need to return the wine, even if it costs you money and effort. Undoing anything a prospective patient has done on your behalf is crucial to make the boundary clear to outsiders. Well, I could go on forever. I am the only boundary between many of you and lunch or maybe cocktails. So I will stop now and turn things over to Dr. Groffman. And thank you.
Thank you, Dr. Appel, for that wonderful talk that we all enjoyed. No, you couldn't see everyone's faces. Um, I want to introduce Dr. Groffman Margalit to be our moderator for today.
Thank you. Thank you, Dr. Appel, for this such interesting talk. As you were talking, I was thinking, we mentioned sex, we mentioned money, but we didn't talk about politics. And one thing that I'm curious about, especially trying to see if what's been happening around us and other countries as well, in what ways we can figure out how to look at these questions and address both political entanglement.
Absolutely. I think there are two different areas. It's often talked about in the context of therapy, where it may be relevant to the care. And I think it's easy to take a non-judgmental regard, reason to set that up as your rule. So in therapy, I will never give answers that affirm someone's beliefs, but I will often give answers that suggest that I'm not rejecting their something like, that's an invaluable way to view the world, or that's an interesting way to view the world. Let them keep going. Or I never thought about it that way. However, the problem occurs when your politics are on your sleeve outside the office, when your website has large pictures of your favorite political figures, or you wear your Stalin jacket walking down the street, or whatever it might be. And so I actually think in the modern day and age, providers need to be a lot more careful about how they share their politics outside of therapeutic relationship. I don't know whether you can be an activist in the same way that you could 30 years ago in the social media world.
This is an interesting point, because I think that this is exactly what I was trying to refer to. In what ways we can still, have our own voices and be active in our own ways, but also make sure that this doesn't interfere in the therapeutic settings.
So one thing that's interesting, you're actually seeing more and more a selection process before accepting a therapist. People or psychiatrists, people actually go online and look to find out what your politics are. They will go, certainly high-end patients will go to things like, Open Secrets, and look at your political donations. Because I've had patients say that to me.
Right. That's an interesting example. It's I've been also addressed and asked those questions both about, it's easy to know from my name that I was not born here, and also based on that, things that relates to both religion or political aspects. In the interest of time, I will also read the first question from our Q&A. And Lisa here is asking, in the example of contributing words for a funeral of a patient, what about the standard that patient confidentially survives death?
Sure. So I think in any situation where you're going to speak, the two things you need to do are, one, you need to work out with the fact you shouldn't volunteer to do any of this. The family should solicit you, meaning they know about the relationship. And presumably, if the wife knows about the relationship, she can stand on a street corner and tell anybody, so it's no longer confidential. But you want to work out the ground rules of what you want you to say to other people if they ask, out of respect for her, not necessarily out of respect for the decedent. But then you obviously should not share anything shared with you in confidence by the patient. So you shouldn't say, "I'm so glad that patient X overcame X, Y, and Z." But I don't think it's a bridge too far to say, "Fred was a lovely person and I'm going to miss him," which is usually what people want to hear. Great question.
I don't treat elderly people as much, but I'm curious, if this is a common theme, right? Of as you are approaching end of life, and you were thinking about like whether you want your therapist to be involved and you want them to share the respect and come to the funeral. Another question that here at the Q&A, can you speak to the way these boundary violations may arise in treatment for minors with primary caregivers or the child? In what ways similar and or different for therapists primarily treating children and adolescents?
Sure, and I will. I am generally not a child provider, which is much more complicated. In the sense that sometimes you'll be treating multiple people in one home. There are a range of legal rights the parents have to know what the child shares with you in a range of areas, and even there are areas where parents may not have legal rights. In practice, they have ways of figuring things out. Their access to insurance, and medicine access, prescription lists. So I think the best thing you can do is to work out in advance ground rules with the minor patient. You should really be clear up front. There are some things that you cannot keep secret, even if you want to, and some things that you will try your best to keep secret, but may not be foolproof. The reality is people are often afraid if they do that, people are going to not share information with them. It's actually more like the Miranda rights. The data shows that if you share people with their Miranda rights, they still tell the police exactly what they were going to say anyway. Only they don't feel as violated when it happens. In my experience, when you tell people that you're going to share information if you have to, they still want to confide in you. It's rare they don't.
Another question that came from the chat is, should you ever attend performances by patient in the arts?
I would be very reluctant to. I think if you did that, the number of ground rules you need to work out to answer that are going to be really complicated. For example, what happens if you run into another patient of yours at this event? That patient will begin asking specific questions. Are those so-and-so also your patient? You could say no, and that won't be credible. It leads to a slippery slope of additional questions or risks. Not to mention which, going to someone's funeral can be a very poignant, important thing for them. Going to their art exhibit may be a kind thing to do, but it's not going to have the same kind of transformative effect if you say no. And most people understand, I think, that if you say no to that, it's part of the work.
I was wondering about it also in regard to like younger kids. It's like sometimes for them graduation can be, one thing that they worked hard and actually was part of like the treatment goals, and like in what ways we can both share this moment with them without then finding myself like in a position where we are crossing a boundary.
Well, I think that's a great point, because sometimes if a specific task is part of the treatment goal, then the value may outweigh whatever the danger is, and you may work out specific goals. Usually people ask you to come to an art exhibit because they're proud of their art. But if you treated them for 30 years because they were afraid to paint, and suddenly they were able to paint a painting, that might be a very different story.
I see another question here. Lisa asking, Dr. Appel asked about the guidelines of the American Psychological Association regarding the obligation to report another provider who is engaged in a sexual relationship. Although it is some time ago, we consulted the American Psychological Association about the situation. A clinical outside of our clinic was sexually involved with one of our patients. APA specifically advises that we could not report this clinician because it would violate the confidentiality of the patient. Rather, we work with the patient to report the clinician herself, which thankfully she did, and the clinician lost their license. I don't know if this would still be true today. This is
that's very helpful. Now, what I'd be curious to know is whether New York state law matches that guidance, because we discovered in several of our cases where the guidance from professional organizations and the state rules actually were incompatible. And then what do you do? I mean, that rule actually makes perfect sense to me. I think whoever handled it well, and it's a good guideline. But if the American Psychiatric Association had a policy like that in New York State, it would still be illegal to follow it, which is why this area needs, I will emphasize, in boundaries, probably the most important goal is uniformity. Everybody should know what the rule is. If you don't know what the rule is, that's when really dangerous things happen. But thank you for looking that up, for sharing that.
I think one last question for us, if I'm looking at the time. When treating children, how do you think about treatment for the parent, both in acute situations, so parents with suicidal ideation, and more general mental health concerns, while making clear you are not the parent's provider, and also know it's the child's best interest to have a parent with stable mental health?
Yeah, so a lot of that is a clinical question, which is way above my pay grade. I think the ethical question, though, it's always important for you to know who you're treating, who you're answerable to at a given point in time, and it's always important for the patient or the family to know who you're treating and who you're responsible to at a given point in time. You don't want a situation where you're helping the parent because you think it's in the best interest of the child, but they think you're helping the parent because your primary duty is to them as a patient or the human being or whatever it might be. And those lines may sound subtle. I don't necessarily think you have to sit down with a patient and spell out, I'm this person's doctor, not that person's doctor, but more conceptually in your own mind, you need to know who your primary servant is, who you're primarily serving, which will help you shape what you do. It's a great question. Can I offer a closing thought before Dr. Groffman? I just want to thank you for all for coming out, but I want to say is there are so many names here I see on email and so many excellent questions. And there has to be a better way for the psychiatrists in our large department and the psychologists in our large department to share their expertise and connect with each other more often. I don't know how we do that, but I think we should do this more often because it'd be a wonderful thing. And thank you.
Great. Great.
You again for this beautiful talk. I think that it probably raised many questions to all of us regarding like how to treat, of our patient, but also address some philosophical questions and practical questions about how we treat and address those notions.
And if anybody would like my slides or individual questions, please definitely reach out.
Yeah, back to you.
I'll just jump in here because you're talking about wrapping up, and although I'm sure people have lots of other questions for you, I want to add that we appreciate your talk, and you're right about that we all need to collaborate and have opportunities to chat with each other more. Dr. Appel, if you want to put your email into the chat, sometimes presenters will do that if people want to reach out to you with questions or about your slides or anything like that. Someone had a question in the chat about slides, so that's going to be up to Dr. Appel.
I'm glad to send you slides. You're welcome to email me at the Mount Sinai email, but if you want the slides, email me at my own address because the server won't accept a large file.
And Dr. Appel's talk is being recorded and will be uploaded to the Mount Sinai YouTube channel along with other talks. So maybe it is time to wrap up. I want to thank you all for attending Psychology Grand Rounds today, and thank you, Dr. Appel, for your fascinating talk. Thank you, Dr. Groffman-Margalit, for moderating. Everyone, please join us at the next Psychology Grand Rounds. We're taking a break in the summer, but we will be back in September. So September 5th is the date. All right. Thank you. Take care, everybody.